So I'm Dr. Benjamin Levy. I'm an associate professor at the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. What to do with a patient who develops disease progression on targeted therapy is really an area of research, and we're dealing with competing standards. And I think it really depends on which target you're talking about. And I'll just try to take the most common targets. For patients that are EGFR mutated, if they have a sensitizing mutation and they are on osimertinib and they develop disease progression, the standard of care off of a clinical trial is generally chemotherapy. Now, whether you add bevacizumab to that regimen or even whether you add bevacizumab plus immunotherapy as well, I don't think we know yet. I think we're still trying to understand, and this is one of the most common questions I get from community oncologists is, what do you do after disease progression? And I would say the standard off a trial is generally carboplatin, pemetrexed-based regimen. Sometimes bevacizumab is used. Sometimes I will use the Empower 150 regimen, carboplatin, paclitaxel, bevacizumab, atezolizumab, given some of the subset analysis we saw. I think there's a call for clinical trials in this space, and we're learning about the importance of identifying mechanisms of resistance. So I think understanding biopsying patients, both tissue and liquid with EGFR mutations, so we can understand mechanisms of resistance, including things like MET amplification. So patients that have MET amplification post-osimertinib who develop disease progression, we have trials from that space. We have drugs, savolitinib, looked at in several trials, and the Savannah trial, an oral therapy targeting MET. So we're learning more. The science is evolving, but off of a trial, I think chemotherapy with bevacizumab, considering a 4-drug regimen. I think for ALK-rearranged lung cancer, it's also a little confusing. I think patients right now, generally with ALK-rearranged lung cancer, they start with alectinib or brigatinib, but we do have an approval for patients with ALK rearrangements who are on alectinib. We have an approval for lorlatinib, which is another tyrosine kinase inhibitor. So we don't have that in the EGFR space, but we do in ALK. So patients who have ALK rearrangements, who are on alectinib, who develop disease progression, lorlatinib is an option for these patients. Once again, we're trying to learn which patient responds best to lorlatinib. And to make matters even more confusing, lorlatinib just had a presentation at ESMO showing really impressive in the front line. So how we make sense of all this, we're still learning. Other genotypes that are in common that we deal with trying to understand resistance, ROS1 rearrangements, which is another common driver. We generally have 2 options, either crizotinib or entrectinib. Both of those are for patients who have not received a ROS-directed TKI. And again, upon progression, we're learning as what to do. And we have early data that lorlatinib, once again, has response rates in crizotinib refractory, ROS1 rearranged lung cancer. And another drug you're going to hear a lot more about called repotrectinib is a drug that is specifically developed to overcome resistance in the ROS1 setting, showing impressive outcomes. And I think we're going to get an approval in the next 6 to 12 months. BRAF mutations, again, we generally start with dabrafenib and trametinib. For these patients, what to do upon progression, we really don't know. I think, again, chemotherapy, probably with immunotherapy, is the general rule. I would just say that for all the other gene rearrangements that have now targeted therapies approved, we generally want to start with the targeted therapy. And when that targeted therapy no longer works, we look for clinical trials for these next generation targeted therapies, or we consider chemotherapy. And the question comes up again, like it does in the EGFR space. Should we be using immunotherapy post-chemo, post-targeted therapy with chemo? Should we immunotherapy or not use it at all? So I think we're still learning this. And this is such a complicated area and one that takes a lot of medicine as an art and not a science in some of these genotypes. So that's kind of a broad stroke overview. Probably EGFR is the one that people see the most. And I would say off a trial, certainly chemotherapy with bevacizumab or chemotherapy alone, or a 4-drug regimen, if not a clinical trial.